Welcome everyone to the Spalding Tri-Model System series, Traumatic Injuries as Chronic Conditions. The sponsoring entities today are the Spalding New England Regional Spinal Cord Injury Model System, the Traumatic Brain Injury Model System, and the Boston Harvard Burn Injury Model System, all of which are funded by the National Institute on Disability, Independent Living, and Rehab Research. We hope we have a provocative program for you today. Our speakers are Michael Chu, who is Chief Medical Officer at Paradigm, Dr. Flora Hammond, who is Professor and Chair at Indiana University School of Medicine's Rehab Program, Donna Capello, a TBI advocate, David Estrada, an SCI advocate, and Deanna Tenney, a burn injury advocate. Our discussants are Dr. Giacino, who is Professor of PM&R at Harvard Medical School, Dr. Jeffrey Schneider, who's Associate Professor of PM&R at Harvard Medical School and the Director of the Burn Model Systems. I should note that Dr. Giacino is also Director of the Traumatic Brain Injury Model Systems and the Director of the Disorders of Consciousness Program, and myself. So our goals today are to recognize the importance of defining traumatic injuries as chronic conditions, explore the similarities and differences of the long-term impacts resulting from traumatic brain injury, spinal cord injury, and burn injury, and realize the potential, which is profound, of among the largest data systems in the world to advance research and policy agendas in these areas. So when I think of this personally, I think that there are inordinate opportunities linking biopsychosocial issues, exploring common biological mechanisms, understanding pathways for treatment, thinking about common risks, understanding the medical factors and how we prevent problems, reviewing issues such as housing and food security, behavioral health issues, and long-term cost. So I'll show you quickly a paper that we did that explored some long-term issues in the concussion population as a predicate for all of this. We did a review of 15 years worth of records within our health system and followed people over 10 years. The end of this was 28,000. And then we eliminated people under 18 and people with existing comorbidities. And what we were able to discern is we were looking for, once you had a concussion compared to controls, and then later in another paper soon to come, injury-based controls, what happens to these people over time who've never had any comorbidity, never any medical issues? And so some of the results are rather stunning. We matched these persons on age, race, and sex. And what you see here are some profoundly interesting hazards ratios, likelihood of an event being diagnosed over that period of time for hypertension, hyperlipidemia, coronary artery disease at 1.9. And we saw these even in early life, 18 to 40. Similar findings were seen in endocrine-related issues that I don't have time to show you. And most profoundly, we saw some of these in a comparison for behavioral health comorbidities. Depression, threefold, bipolar, almost threefold, suicidality, substance abuse, anxiety disorder, and even schizophrenia. Here we show time to event. What you can see here is adjusted for age, sex, and race. These things occur generally within the first 5 years for depression, sleep disorders, and anxiety. So there's reason at least to explore that these chronic conditions are chronic in so many different ways. So I hope I was provocative in initiating the discussion. To submit questions for our speakers, please use the Q&A feature. All questions will be read aloud at the end of the webinar. You will receive a brief survey by email to complete after the webinar. Your feedback is valuable for determining further sessions. Now what I'd like to do is introduce one of our featured speakers, my good friend and collaborator for years. Dr. Hammond is chair of the Department of Physical Medicine and Rehabilitation at Indiana University School of Medicine. She's also chief of medical affairs and brain injury medical director at the Rehabilitation Hospital of Indiana. Dr. Hammond is project director of the Indiana Traumatic Brain Injury Model System and chair of the TBI Model Systems program executive committee, I can only share that Dr. Hammond is a thought leader in this area and really a tour de force in the area of brain injury on understanding how we might explore such issues. Flora, we're thrilled to have you.
So what I'm going to explore with you today is how changing our paradigm of thinking about brain injury, spinal cord injury, and burn to a more chronic condition model might be able to change outcomes, reduce cost, and achieve what we're trying to do with these conditions. We, as rehabilitation professionals, have known this for a very long time, that these are chronic conditions. It's obvious to us. But if you look at the infrastructure and the care that these individuals generally receive, it's front loaded. So we've got solid resuscitation and acute care, and some people get acute rehabilitation, and then it starts falling off where people are not always followed throughout the lifespan, when there's actually times when there are things that we could actually be addressing for them to improve their outcome, their function, and monitor their medical situation. So hopefully what we're going to be doing with considering these diseases as chronic conditions is building out the bridge to support them through the lifetime. So it's obvious the chronic impacts, from impact on function, participation, additional comorbid conditions, the cost, the additional healthcare issues, and even mortality, quality of life issues that come with all three of these, or may come with all three of these conditions. But what can we do about it? So many chronic disease many chronic conditions, payers have noticed for years that most of the healthcare dollars are going to support these chronic conditions. And wouldn't it make sense to have a more proactive approach, a structured disease management approach for dealing with chronic illness, so that we are improving health, reducing cost, reducing use of the ER, reducing complications, and overall improving both outcome and reduced cost. However, despite this push towards chronic disease models over the past couple decades for other diseases, we still don't really know a lot about the long-term impacts of chronic disease models. I'm going to share with you today a couple of the main disease models that are used for other conditions. For example, asthma, diabetes, congestive heart failure. There's several other diseases that have really embraced chronic disease management approaches and seen better outcomes. This slide shows you that there are 21 conditions recognized by CMS, Medicare, and one of the things we've been talking about is really there should be more than 21 recognizing spinal cord stroke and burn. I'm sorry, spinal cord brain injury and burn, to be able to get the best outcomes possible for our patients. So there are a lot of different approaches. The main two mechanisms are integrated care models and collaborative care models. But in general, on this slide are common elements found in most models, is generally evidence-based. There's usually specific screening in place to identify an issue as it arises so that it can be proactively treated. There's comprehensive workup and clear treatment priorities that map onto the patient's goals and values. There are established goals of care and a written plan of care. The care is protocol driven and adjusted based on how the patient is doing. There's specific target measures. For example, for congestive heart failure, you're following weight. For diabetes, you're following blood sugars. That you can target, you can follow a measure and then target an adjustment to the care, and you can follow adherence to the treatment. And oftentimes there's collaborative care. So for example, a primary care physician might be working with a rehabilitation physician to improve the care when in complex patients, or a primary care physician might be working with an endocrinologist, et cetera. And as we'll talk about in a few minutes, there's generally a lot of efforts towards supported self-management, which requires education of the people with the condition. So the first, I mentioned there's integrated care and collaborative care as the two main models. This here is the integrated care model. This is also called the chronic care model. It's based off of Wagner's work. And basically Wagner's work is taking the community as a whole combined with the healthcare system to have an informed, activated patient and a prepared, proactive practice team. And that includes, from a community standpoint, the patient managing their issue, supported self-management, a supportive environment, and public policy and resources to support people with health conditions. And in the healthcare system, delivery system design, decision support, and clinic information systems. What does that mean? Delivery systems mean basically knowing who's at risk and managing towards that risk, and having case management for those at highest risk, and expert clinical teams. Decision support means that we've got guidelines. We know the established guidelines, evidence-based guidelines. There's seminars to increase capacity, and there's supervision of the case managers and people trying to help the patient with consultant input. Clinical information systems might mean the performance metrics, like I mentioned, and being able to track those and how things are progressing to prompt changes in care, or a registry system. And supported self-management, we'll talk about in more detail in a few minutes. A systematic review of integrated care models involved 157 studies, and what they showed was in almost half of the models that they reviewed, self-management was a key component. And this slide shows you the frequency of the different components being in the integrated care models. So self-management is a common theme, but often these are used together. So these elements aren't used in isolation, but combining these together to do the best care. And what they found in this systematic review was that most studies did show improved professional and patient outcomes. So to dig in and tell you a little bit about what self-management is, Katie Lorig has done considerable work in this area, and I recommend reading her work. There are several models that already exist of self-management for other diseases. And in fact, some of those conditions have overlap with brain injury, burn, and spinal cord injury. For example, depression, pain, substance use, alcohol use, diabetes might be conditions that our patients with burn, spinal cord, and brain injury have, and we could be utilizing some of what's already been learned for self-management and disease management for those conditions. So the importance of self-management is that the average patient spends very little time in front of a healthcare professional on a daily, yearly basis. So on average, a patient spends about 3 hours in front of a healthcare professional. And so that's certainly not enough to be managing their condition. So we really need to be empowering the person with a condition to manage their own condition, to provide them with the education and the empowerment and the infrastructure to do that successfully. It has to be that the patient realizes the problem and, as I said, is activated to address it. So it involves a lot of education, activation, goal setting, and goal support. Generally, there's help with establishing action plans so that the person can follow through with those action plans. And then there's generally mechanisms for self-monitoring and tracking how they're doing on the different measures. 6 basic skills are required for self-management, which make a lot of sense: problem solving, decision making, resource utilization, patient-provider partnership, action planning, and self-tailoring. So these are 6 really important skills that you can anticipate, particularly in brain injury and sometimes in other conditions, might be challenging. And so someone might actually need help in their supported self-management. Maybe it's a family member or friend who's helping them, or more intense case management that's helping them. So the other model I mentioned, so we talked about integrative care. Now the other model is collaborative care. And what I'm going to show you is a model from University of Washington that's been done for multiple sclerosis as well as spinal cord injury. And this model with the patient as the center includes physicians, medical personnel, as well as expert consultants, medical personnel, working with a collaborative care manager to accomplish the needs of the patient. And this is an example for spinal cord, but it could be applied to many other conditions. So here in this example, it's a spinal cord physician and nurses, but I've seen it in other models where this is a primary care physician. So basically the physician and patient work together to identify the patient's choices. The patient needs to be driving the treatment choices to make sure it's consistent with their goals. And then there's continual feedback between the collaborative care manager to help and the patient to help with decision support and care coordination. The collaborative care manager is working with the patient one-on-one to motivate and enhance adherence and provide brief treatments during their interactions and facilitate follow-through. And there are generally weekly case conferences between the experts and the collaborative care manager and the physician to see how they're doing, are they on target, and make changes to the treatment to make sure that the target is reached. And this on the right-hand side kind of summarizes the goal of it. And for this example, the issue being pain, that when you have more pain, the person's going to be less active and have more depression and have a lower quality of life. And applying this model for the example of pain, less pain, more active, less depression, and higher quality of life. One important thing to all of these models is being able to identify the risk of the person. So are they very high risk with complex needs, or are they low risk? And this diagram shows nicely that luckily most of the people with a chronic condition are going to be in the low risk strata, and with low risk generally expected that the person will be able to largely do things through self-management. And the higher risk someone is, the more intense disease management or case management is needed to be able to meet those needs. So higher risk, more professional management; lower risk, more ability to do self-care, and the importance to be able to identify someone's risk. And there's still a long way to go in regards to all of these conditions that we're talking about today, and being able to readily stratify one's risk. One of the things we're doing in brain injury, we have been working on this for the past decade and still have a long way to go in regards to what are we actually doing in the clinic when we're seeing someone with brain injury. So the NIDLR, the National Institute on Disability Independent Living and Rehabilitation Research, has recently funded a grant using the TBI model systems infrastructure, where we're going to review the literature from these other conditions, the diabetes and hypertension and pain and depression and asthma, and learn what they did and see what aspects of those models are applicable to brain injury and what needs to be changed. This is a very intense look at what kind of model is needed, what's the staff expertise, what kind of communication needs to happen across healthcare professionals, and what changes need to be made to the EHR, electronic health record, what kind of billing implications. So we're going to put all this together. We're going to take an intense look at self-management. After we've done the evidence-based reviews, we'll then be working to see what kind of model is best for brain injury, and then do some feasibility studies, and then hopefully as years go forward, be able to roll out a more robust model for managing brain injury as a chronic condition. And I know burn and spinal cord are moving forward in their areas to where the field is at this time.
Thank you very much, Dr. Hammond. Somehow my video stopped, but that's okay. There I go. I want to introduce our next speaker. I want to thank Dr. Hammond, though, for an extraordinary overview and talk, and then introduce my dear friend and collaborator, Dr. Joe Giacino. Dr. Giacino is the director of the Rehabilitation Neuropsychology at Spaulding Rehabilitation Hospital. He's consulting neuropsychologist in the Department of Psychiatry at Massachusetts General Hospital and professor in the Department of Physical Medicine and Rehabilitation at Harvard Medical School, a thought leader in the area of brain injury and severe brain injury. It is my joy to introduce Dr. Giacino.
Thank you, Dr. Zafont. Can you all hear me okay? I hope everyone can hear me. Yes, okay. So I'm not going to use slides, I only have about 5 minutes, and then I'm going to introduce the featured speaker from TBI in a moment. But you know, I just want to make a few comments to sort of set the stage in the first 5 minutes. A little bit about the TBI model system. So the TBI model system program is the largest and longest running longitudinal database in the world on outcome in adults with moderate to severe TBI. It was established 34 years ago. There are now 16 funded TBI model system centers that are distributed across the country. And the database now includes more than 18,000 people with moderate to severe TBI. And we've done over 70,000 follow-ups to date. So there's a wealth of knowledge in this database. What have we learned about the course of recovery? Well, we know that while many people with moderate to severe TBI eventually recover independence and go on to lead productive lives, most continue to experience physical, cognitive, and or emotional changes that affect everyday life. We also know that after the first year post-injury, the course of recovery begins to go in one of 3 different directions. People continue to improve, they stabilize, or they show decline in function. So more specifically, we know from the research done by the model systems that about 25% of people continue to improve over the course of the first 5 years. About a little bit more than 20% start to level off and stabilize. But of concern to all of us, about 50% of individuals with moderate to severe TBI show some decline in function over that course of the first 5 years, particularly after the first year. And even more alarming, we know now that about 20% of people die within the first 5 years. And that figure is particularly concerning because it occurs across different ages. This is not just at the older age, in the older age span. Why is this? Well, we don't know, but we do know that individuals who have had moderate to severe TBI are more susceptible to other health problems that either arise directly from the injury or are related. So for example, seizures are 50 times more likely in somebody who's had a prior brain injury than somebody who has not. Infections are 9 times more likely. So these things certainly make life more difficult. We know that about 50% of individuals are rehospitalized at least once after their initial injury. 1 in 3 need care from someone else to help with everyday activities. 1 in 3 say that they're not satisfied with their life, not surprisingly, because they have the burden of these additional problems to contend with. And another 1 in 3 have difficulties with substance abuse. 1 in 10 actually have to be in an institutional setting because of residual problems from the injury. Now, these problems that I've just talked about tend to be more common in people who are of older age and leave rehab with greater disability. Nonetheless, this is a particular problem that's only recently been recognized, and one that we're all here to discuss, as we need to really home in on this. But I also want to emphasize that even after very severe traumatic brain injury, recovery can continue through the first 10 years post-injury. Work done by Dr. Hammond recently and others show that that recovery curve continues a full decade, and as many as 1 in 5 people who have had prolonged disturbance in consciousness, so really severe disability, eventually recover independence over that 10-year span. So that's real cause for optimism here. So to move ahead, what do we need to do? Well, we need to better understand who's at greater risk for decline. We need to understand what pre-existing conditions require management. We also need to be alert to conditions that develop after the injury so that we can try to prevent them or at least detect them early and get management underway as quickly as possible. Very importantly, we have to improve access to medical, rehabilitative, and community-based care to improve function and reduce negative outcomes. And lastly, I think the model systems needs to partner with other clinical and research organizations to advocate for policy and regulatory changes. So that sort of gives my perspective. I'm going to now turn it over to the star of this part of the show, who is Donna Capello. So Donna is a former registered nurse who, during her career, provided care to the homeless and those with terminal illness. In 2005, she sustained a severe traumatic brain injury as the result of a fall. Her recovery course has been a long and winding road, but she eventually recovered her independence and now lives alone, manages her own affairs in her own home. She's a participant in the Spalding Harvard TBI Model System Program and just recently completed her year 15 follow-up. Thank you, Donna. It is my pleasure now to invite Donna to share her perspective on how TBI has impacted her life and requires ongoing adjustments to cope with the long-term effects. She's accompanied today by her son, Jack, who's going to help out with the technology. So Donna, you have about 5 minutes to tell us about your experience. Jack and Donna, take it over.
Hi, my name is Donna Capello. I sustained bilateral skull fractures in 2005 after a horrific fall down my brother's concrete stairs, rock stairs in New Hampshire. Had to be shipped off to Mass General, where I originally had to undergo 3 skull surgeries because I had a huge hematoma, and then had to go back and have 2 more. I had 2 pieces of my skull placed in my abdomen, was on G-tube feedings and induced in a coma. Finally was put into Spalding rehab, where I was a Looney Tune and tied down to the bed because I had no memory. Everything happened. And then one day I undid all my things, was found at the sink brushing my teeth. The doctors came in and were temporarily blown away. I didn't know at that point that I had to wear a helmet, but Spalding Rehab and Mass General have been phenomenal in my care. sadly, I had to go under a total of 11 skull surgeries due to there was metal put in and they figured it was too much. So in October, I had my 11th surgery where the metal was taken out. And due to the COVID and everything that's going on, I have not been able to go back to have follow-up and also follow up at Spalding Rehab because the hope is to restart physical therapy. I've been very blessed because my children have done phenomenal for me, and I fought to get guardianship back for them. I fought and got my house back, and I'm blessed because, like I said, we lost my husband, who was a platoon sergeant, and he was our angel. I told them he'd strike them all with lightning if they did anything wrong to me. And I believe that's what our Rock and Roll Hall of Fame was. And I've been blessed that I'm still here strong. And hopefully once COVID chims down, I can restart PT to gain my strength. My children are here to help when I need grocery shopping so I don't expose myself to all the crapola that's going on. And I'm very blessed and honored that I'm a patient of Spalding Rehab, where they were phenomenal for me, and Mass General, where they did everything to kick my butt back and allow surgeries that put me back on this earth. And I just hope it continues, and I hope one day that I can restart PT and get rocking again. If I can roll the boat in the Charles River, I can do about anything. And I'm very blessed.
Donna, thank you so much for taking the time out to share that story. It's one that I think a lot of people can identify with. So thank you. And thank you, Jack, for your help. We're going to move along now, and I'm going to introduce the next person who's going to tell us a little bit about his experience from the spinal cord injury side of the story. And that is Dave Estrada. So Dave is a spinal cord injury peer mentor and the former executive director of the Greater Boston chapter of the National Spinal Cord Injury Association. He is research and development coordinator in the exercise program for persons with disability at Spalding Rehabilitation Hospital and the program manager of the Spalding, New England Regional Spinal Cord Injury Center model system. Dave, you're on.
Thank you, Joe. Can everybody see my slides?
We can.
Oh, great. Thank you. Thanks for having me today. And just a quick background about myself. I had a traumatic spinal cord injury in 1995. I spent 3 months of rehabilitation time in the hospital. And back in 1995, I left the hospital without any real long-term care plan, even short-term care plan. In fact, I did no outpatient therapy after I left the hospital. So I basically learned how to use a wheelchair, had my supplies that I needed to do what I needed to do after living with a spinal cord injury. And I had no local primary care physician. And again, no real physiatry follow-up plan. So the good fortune that I had after my injury and spending 3 months in rehab and then going back out into the community is meeting someone else with a similar injury who I thought, finally someone I can talk to who's been through what I've been through and is living successfully. So he was my, not only my mentor, but he taught me probably, things that I tried to learn in rehab that I didn't learn, either because I didn't want to learn them at that point in time or because it was just not clicking. So he was my my person to go to for any troubleshooting issues that I needed after discharge, and I'm back in the community. I have seen a urologist, I think, 3 or 4 times in 25 years. I finally found a primary care physician about 8 years after my injury. And I have been technically, specifically speaking, lucky that I am been pretty healthy as a T3 complete paraplegic for again the past 25 years. So a lot of things that I think are not available in terms of chronic, long-term chronic care are available in the community to a lot of people. So I'm also involved in the Greater Boston chapter of the United Spinal Association. It has a big peer mentoring and support group program function in the community, as well as at Spaulding Rehab Hospital in Boston. And so for me, again, when I was injured, I still needed to work on wheelchair mobility skills and just be more educated about spinal cord injury, which again, I received from my mentor and really no one in the medical community. So it was sort of trial by fire to me, although 3 months in rehab compared to 4 to 6 weeks now in rehab probably helped me substantially as compared to if I was injured today. You know, I can say it's hard to be your own advocate after an injury, any traumatic injury that is significant and life-altering. There are many obstacles that you face physically, mentally, and insurance. Obviously, I have fought my insurance company many times over the years for, you know, wheelchairs, for medical supplies, et cetera. So the challenges are there, short-term, long-term, and they're continuous. You know, I have wound up in the emergency room plenty of times over the past 25 years. And each emergency room is different. You know, we live in Metro Boston, and so there are plenty of hospitals to choose from to go to. And each hospital that you do go to, you don't know what kind of care and treatment, what kind of knowledge the staff has. So it's sort of like rolling the dice when you wind up in an emergency room if you live outside of Boston or even inside Boston. Mental health services weren't really in existence when I was injured. I don't remember being offered mental health services. So I sort of coped with my injury on my own. And then again, when I met someone in the community who had a similar injury, that was my foray into mental health services. And there's still a struggle. I mean, we do a much better job now, and we being Spaulding Rehab, than we ever have before in terms of offering mental health services to inpatients and outpatients, but community resources for mental health services are still challenging. There's no one-stop shopping in spinal cord injury. You have all these different secondary complications that can arise, and there's a specialist for pretty much every complication that you can have. And whether you're in network or out of network, meaning your insurer will provide, you know, offer services to certain physicians or specialists, that's another challenge that is a long-term challenge. So the multi-health issues that we do face are many. And again, there's pretty much a specialist for, although we see physiatrists who are specialists in spinal cord, traumatic brain injury, and other neurological conditions, a lot of these conditions can't be handled by just a general practitioner, a primary care physician. We need specialty care, specialty treatment. And figuring these things out on your own is next to impossible. And treating them long care by yourself, again, is next to impossible, which is, you know, just another reason why we need to promote spinal cord injury, brain injury, and burn injury as chronic conditions. So what do we do to sort of plug the holes or fill the gaps for long-term chronic care? And again, due to the lack of access, people often turn to advocacy groups like United Spinal, like the Christopher Reeve Foundation for information. They turn to peer mentors that offer quite a few services, support services, but no medical services, I should say. You know, a lot of people just go to the internet and try to look up their condition, any condition that they may have, and figure that out by themselves. So there is a huge need for long-term chronic care for spinal cord injury. Future directions. To continue to work on improving transitions of care from inpatient to outpatient to the community to long-term care. That includes research, collaboration between disciplines, consumer advocacy groups and policymakers. I think that's our really major milestone or next step for us to bring all these different groups together and literally hash out what is possible. You know, building networks that allow better service to the SCI population. For example, Spalding is part of Mass General Brigham Hospitals. You know, I think there could be an improvement in that aspect of connecting the dots for patients who receive acute care, say at Mass General, then go to Spalding, then are discharged and back into the community. You know, follow-up, more frequent follow-ups, and coordination of care, as well as we know, we're in an electronic age, and we're now doing a lot of electronic medical records. So opening those medical records to primary care physicians that can collaborate between the peak primary care physician and the physiatrist. That's always helpful. And incorporating persons with spinal cord injury into the healthcare workforce, persons with disabilities in general. I think we're way behind on that. We're improving slowly, but could do a better job at that. And I know we are trying, and I know we'll get there in time. So thank you for your time. Thanks for listening. And here are a few websites that you can take a look at to review if you'd like. And now I'd like to introduce to you Dr. Schneider. Dr. Schneider is the program director of the Boston Harvard Burn Injury Model System. He's a medical director of the Trauma, Burn, and Orthopedic Rehab at Spalding Rehabilitation Hospital. He's the division chief of comprehensive rehabilitation and associate professor of physical medicine and rehabilitation at Harvard Medical School, excuse me. And he's also the director of Rehab Outcomes Group of the Rehab Outcomes Group at Spalding.
Thank you so much, Dave, for the kind introduction, and more importantly, for sharing with us your personal story and your really thoughtful perspective on spinal cord injury in this context as a chronic condition. I want to, in the interest of time, just move on to the next speaker, and it's really my pleasure to be able to introduce Diana Tenney, who I've had the privilege of getting to know over a number of years in multiple different capacities, and as someone who I've learned a lot from. Diana is a burn survivor. She's a certified peer supporter. She's the president of the Burn Survivors of New England, the premier burn advocacy group in the New England area. And she's also the co-director of knowledge translation at the Boston Harvard Burn Injury Model System. And it's my privilege to introduce Diana, who I think will be providing a recorded version of her talk here today for us. Thanks, Diana.
Hi. Apologies for not being there with you live today. Schedule wouldn't permit, so we're doing the wonderful virtual recording thing. I'm Diana. I was burned almost 11 years ago at the age of 54, 94% mostly full thickness. I was made aware that most likely I would suffer from contractures, scarring, and itching and need lots of physical activity for the rest of my life. It was suggested that because of my appearance, I was going to have trouble with social reintegration. I wasn't told about the effects of the systemic changes that my burn injury would bring, the secondary complications of my health care, or the reluctance of primary care and other medical disciplines to take care of my unusual health care and uncommon medical procedures and diagnostic testing. I was in pretty good physical condition pre-burn, and my immune system was good enough to carry me through the first 90 days post-burn with no infections. But then during my acute care and rehabilitation stays, I went into total renal failure, had heterotrophic ossification in both elbows. Of course, a severe infections, some treatable with antibiotics, some not. Even though I underwent post-burn reconstruction for 7 years, my quote, regular healthcare needs were put into the hands of mainstream medical professionals after 2 years. I've been refused removal of my gallbladder. I have 3 large gallstones with periodic severe pain. It could be my liver, we don't know, because I've not had wellness check diagnostic labs in 4 years because of lack of vein access. I've been refused a colonoscopy, even though there was a prior resection of a ruptured diverticuli, and mammogram until 10 years later when it was arranged for me to have a bilateral ultrasound, which how effective, how telling, we don't know. I've suffered severe consequences of a vitamin D deficiency, although research was available on permanent vitamin and mineral deficiencies of burn survivors. During a 9-day hospitalization, 5 years post-burn, I was told that I would either go into renal failure or would have a heart attack. The diagnosis, which was by a dermatology team, was HSP, an autoimmune disease that usually happens to male children 9 years and under. Go figure. Because my body swelled up so severely, I developed fistulas and graft separation requiring submandibular salivary gland removal, not to mention blisters from my knees to the bottom of my feet, causing more scarring. A side note, shortly after discharge from the HSP diagnosis, I was sent a letter by SSDI to requalify for disability. To this day, I have frequent episodes of cellulitis, folliculitis, and open recurring wounds. Through most of the conditions I've just described, I've had to act as my own primary care doctor because of a non-responsive doctor. I have settled for less. When we are discharged from the burn unit into the care of the mainstream medical community, not only do we not understand the extent of systemic changes, our mainstream medical community does not recognize at all or understand special needs and are reluctant to spend the extra time and energy to see their healthcare needs are met. When I read the medical records of my 6-month inpatient stay at MGH, I was amazed at the number of consulting specialty medical professionals that attended to every condition and crises that came along. Months before my planned discharge to Spalding, there was collaboration between the two about my care. Why isn't this being done with our continuity of care post-discharge from the burn unit? Is it due to the fact that it hasn't been officially recognized that burns affect us for the rest of our lives? Are we even utilizing existing research and doing new research on post-burn conditions and disseminating that information to not only the burn survivor and caregivers, but the medical professionals? I remember the days when my medical records were carried with me to the OR. They were thicker than a set of Encyclopedia Britannicas, if you remember those. Do you think my primary care has time to read through my medical records to learn about the conditions that I had during my acute and rehab care, and then look up the existing research, or lack of, to see where my medical care focus needs to be? Through my own experiences with post-burn healthcare, confirmed by talking with many other burn survivors through peer support, that answer is resoundingly no. One thing that is clearly put to us when we are certified for peer support is that we do not cross over the medical boundary line. But many times, burn survivors turn to burn survivors because they are not getting answers from primary care physicians or other medical disciplines. Many times I have referred burn survivors with medical issues back to their burn units, even to get the right antibiotic for cellulitis, or the refusal and reluctance of surgeries or procedures that are no problem for normal people. It's a common theme in the burn recovery world that everyone wants us to live our best life, to be emotionally well. That's rather hard to do when we are suffering from physical illnesses and after effects of our burns, whether from systemic changes, pre-existing conditions, or life-saving procedures. I don't even pretend to know the ramifications on insurance policy, procedures that classifying burns as a chronic condition will bring about. I can scream and shout about how we are not being taken care of, but I'm aware that until we change policy, it's going to do no good for me to scream and shout. Thank you for all of the people on this panel and everyone involved for bringing this to the forefront. Now it's up to something much bigger than me to attend to, but I'll help in any way that I can. And I can tell you, the burn community can be a major component and proponents of the move to have burns classified as a chronic condition. Hi, apologies for not being there with you.
Thank you, Diana. That was like a very pointed discussion, not only of your own personal story, but really put into sharp contrast, like the real issues facing people and a real perspective on real life, how this affects people in real life, and how much more work we have to do. So I want to switch gears now to our last speaker. It's my privilege to introduce Dr. Michael Chu. Dr. Chu is the Chief Medical Officer and Senior Vice President of Paradigm. He also teaches emergency medicine, internal medicine, and family practice, residents at Wright State University's Boone Shute School of Medicine. And I've had the privilege of getting to know Michael Chu over the past number of years. I think he has a really unique perspective to share with us on this issue of chronic conditions after traumatic injuries. Thank you so much, Michael.
Great. First, I want to make sure, can everybody hear me okay? Can you hear me, Jeff?
Yes.
Yes.
Perfect. All right. I'm going to see whether I can. There you go. Great. So, well, thank you, Dr. Snyder, for your introduction, and good afternoon, everyone. I do want to actually share before I begin speaking that I feel very honored and humbled to be here with all of you, because I truly believe you guys are the leaders in the field of brain injury, spinal cord injury, and burn injuries, and I think making a tremendous impact on a nation and healthcare. So with that, as the Chief Medical Officer for Paradigm, my goal today is to share some of my observations and perspectives as being in my role for the past 10 years as to what is achievable, what's possible by people with catastrophic injuries, especially if we can make available the appropriate care configurations, as well as the appropriate care management framework that can be available consistently, I think, through the life of our people with catastrophic injuries. So with that, I'm going to go to the next slide. I just want to share with you, I thought it'd be good to share with you some of my my perspectives on what's good, the bad, and I want to actually pose a question to our audience today. And I think it's interesting that having heard the speakers before me, so my inferences definitely, I guess, corroborated, and so I'm happy to feel that I'm on the right path. Sorry about that. So the good news, at least in my mind, over the past decade, that we have been experiencing some tremendous, I think, medical advancements in the medical science arena, trauma surgery, critical care. And I think the good news is that more people are surviving catastrophic injuries. I think that is a fair statement. And in fact, in my review of the trauma registry data that's been kept by the American College of Surgeons, across the country, the survival rate for traumatically injured patients is 96%, which is pretty impressive. And even when you consider the fact that for those that is most, I mean, even severely injured, and most severely injured with ISS scores or injury severity scores greater than 25, it's pretty impressive that the survival rate actually is approaching 75%. More recently, in my review of the model systems data, I mean, the even better news is that people with catastrophic injuries are surviving longer once they, if they, obviously survive the initial event. And I think I came across a study that was published a few years ago by Spinal Cord Injury Model System that showed that the odds of survival actually improved 50% at 1 year post-injury, and beyond 2 years actually improved by 20%. And of course, this is comparing the more recent decade as compared to the earlier ones. So what's the bad news? I see, two areas of, I think, bad news. And one is, I think, it's already been confirmed by some of the speakers, that there still exists a significant amount of knowledge gap in the medical industry. Interesting enough, I probably use the term, there's a asymmetry in knowledge or information. And I think probably the reason for that is because the catastrophic injuries are somewhat uncommon. I mean, fortunately, it's not very common. So I think that it leaves a large percentage or many portions of our medical industry and practitioners to be less familiar with the medical issues and the care needs that are really needed by the population with catastrophic injuries. The other bad news that I see from my vantage point is that at least when it comes to people with catastrophic injuries, I really believe that our healthcare industry, our medical industry, has been more focused on keeping, I guess, the population surviving, rather than trying to figure out how we can help the population with catastrophic injuries to actually thrive. And so this is the question that I wanted to actually pose to all of us here who's attending this session is, do we truly believe that people with catastrophic injuries, if they survive the initial event, can truly survive going forward? Is it truly possible? And from my perspective, my answer to this question is a very solid and strong yes. So why do I feel so strongly about this? Well, 30 years ago, there was I consider to be a brilliant physician. His name was Dr. Nathan Cope. And actually, I had the privilege of meeting him and getting to know him pretty well. And I think many of you may also know him as well. And what's unique about Dr. Cope was that he was a dual board certified in physical medicine and rehab, and also a psychiatry. And he helped to create a company that we now know as Paradigm, which I'm the chief medical officer for. And what's unique about this company is that the vision or the mission of Dr. Cope was to help people who actually acquired a catastrophic injury like traumatic brain injury, spinal cord injuries, burns, multiple trauma, and amputations to actually get their lives back after obviously experiencing such a catastrophic event. And his hope was to turn the worst case scenarios into the best possible outcomes. And the key difference was that his approach was to actually focus on achieving functional outcomes and really emphasizing the need to focus on what people can do versus what they couldn't do. And I love this quote because I do think that this quote really encapsulates the premise of what we just talked about, in that if you focus on the possibilities, I think that in general, lots of limitations can just take care of themselves. So what's been Paradigm's experience? And I'll go into this and see and also explain how we work. But if you would, I guess, agree or assume that the release return to work would be a good proxy for functional and behavioral, as well as maybe a quality of life metric, then over the past 30 years, I can tell you that we've been demonstrating that population with catastrophic injuries have been able to do what I consider to be impossible, which is really getting on with their lives. Where 65% of our population actually have been released to return to work, and which means that they are obviously well integrated to the community and to society. 40% of our population by 2.5 years have found some competitive employment. They've returned back to work to some level of employment. And 15% of our population actually have returned back to their full duty, regular employment prior to the injury. And this is by 2.5 to 3 years. Now, I will say that obviously these percentages do vary depending upon whether you have a traumatic brain injury or spinal cord injury or burns, but as you can see below. But I think the reality is, I think it is very, very possible that and achievable that people with catastrophic injuries can get on with their lives. Additional measures that we monitor, 95% of the injured people and their families have been very satisfied with their experience with Paradigm. 82% of our population actually within 2.5 years requires really no prescriptions for opioids or narcotics to control their pain. And 77% of our population actually were able to achieve functional independence high enough so that they don't need any specialized attendance at home or support systems at home to help them live independently. So I guess, what we, I want to speak a little bit of what we have learned over the 30 years of managing catastrophic injuries. And I have to say that many of the speakers who came before me actually highlighted some of these, but I'm going to do a quick review. So the first thing that I think we all agree upon is that catastrophic injuries are life-altering. I think David said that earlier. And, unfortunately today, it results in permanent impairments that we currently do not have any cure for. We're working on that and we hope to find a solution, but right now we do not have a solution for that. We also know that these catastrophic injuries have significant and profound impact psychologically, where people have obviously markedly changed body image and self-image, forcing them to undergo obviously experience emotional and behavioral reactions. And I think we also realize the importance of both the injured people and their families having to go through the Kubler-Ross's 7 stages of change or grief that starts with shock and denial through depression and ultimately to the stage of acceptance, which I think is very, very important, and especially in the process of getting back to their lives. And then the last component is that we know that there are definite lifestyle changes permanently. And actually, I use the term losses because lifestyle losses occur because of permanency. And there is an importance for us to try to help the injured people and their families investigate, explore, and adopt new lifestyles that hopefully can improve their or optimize their quality of life, as well as social connectivity. The other thing that we learned through our experience is that, as Dr. Flora Hammond pointed out earlier, catastrophic injuries are chronic health conditions. I mean, we already assumed that. Over the years of managing catastrophic injuries, there's probably 500 plus problems that we try to help resolve over the 2.5 to 3 year period of time that we're on the case. But there's always a huge handful of medical issues that become chronic. They become chronic health issues. So really, in our minds, catastrophic injuries are really a chronic health condition that houses a whole host of multiple chronic medical issues. And as a whole, this is the database that we always track from our analysis. The top 2 chronic conditions that kind of bubble up to the top includes chronic pain and obviously depressive disorder or depression. It's followed by cognitive impairment, memory deficits, all the way to altered self-image and even sleep disturbances that I think Dr. Josino pointed out earlier. Now, these conditions do vary depending upon the catastrophic injury category that you're dealing with. So for traumatic brain injuries, I don't think anyone will be surprised to see that the top few have to deal with cognitive impairments, memory deficits, obviously lack of insight. But as you can see, depression, inability to live independently, chronic pain are always kind of at the top of the list. Spinal cord injury, not surprising to see the neurogenic bladder and neurogenic bowels, of course, and sexual dysfunction, but chronic pain, again, depressive disorder, altered self-image, it becomes a very long-standing issue that has to be managed properly to mitigate the complications and overall health status going forward. And burn injuries, beyond the disfigurement and hypertrophic scarring, again, depression, altered self-image. And then you see the temperature hypersensitivities because of all the skin damage, as well as chronic pain and PTSD. So these are, again, a list of chronic medical issues that actually persist, and we have to find a way to make sure that these are appropriately cared for and managed for long term, to make sure that there are no exacerbating medical complications going forward. And then lastly, and I think this was actually mentioned by Diana, which I was very right on the mark, was that we actually looked at how many individual physicians are required or get involved interacting with injured people and their families during the first 2 years of care. And we've done this by looking at the MPI numbers specific to physicians. As you can see, the range of physicians that the injured people and the families interact with the first 2 years can be as low as 40s, but it can be as high as well over 100. Spinal cord injury group seems to have the highest average. But to Diana's point, it just this just shows the complexity of the condition and the need for the expertise and the teamwork that's involved to ensure the best outcomes. And I don't think this type of interaction occurs after being discharged from our acute care facilities. So I want to spend maybe a little time talking about what we do as Paradigm that seems to help us achieve the better outcomes. And the first thing that I want to point out is that, as Dr. Hammond pointed out earlier, we rely on a team of experts, clinical experts who really understand, have the great knowledge about the chronic disease or chronic injury that we're dealing with, as well as they're also proficient in really driving the outcomes or driving the management of these conditions. And we actually have taken on the approach that kind of integrates the category of integrative model and collaborative model. It's kind of a part and parcel model that really adopts the biopsychosocial approach to care management. And as the name implies, we basically evaluate all those factors that within the biological, then the psychological, and the social domains, and appropriately balance them properly so that we can achieve the best functional outcome as well as the best level of social participation. Next is that we also discovered the importance of data. And we use, obviously, the data that we have gleaned over the past 30 years in managing catastrophic injuries to leverage the functional outcome information that we have gathered, as well as other clinical factors, and obviously came up with some analytics, both descriptive and predictive, to come up with benchmarks and to better understand the impact of various interventions and location of service and the types of service to help us to get to the better functional level. And there's no substitute, I think, for having data, and data builds upon the experience and I think the wisdom that the clinicians bring to the table. And then lastly, I think what is truly, I think, different for Paradigm in achieving our outcomes is really our ability to support our biopsychosocial care management approach by paying for and covering those, I guess, so-called non-traditional medical care services that are not covered by other payers, but is essential to help the people with catastrophic injuries to really better manage their health and their illnesses by improving their self-care ability, their self-management potential, and really helps them to improve their self-accountability as they work to achieve their highest level of functional independence and also their long-term health maintenance. And just as a quick example, these are some of the things we cover. We obviously pay for and cover the expert team care management services. We cover the psychological and behavioral health services that many of the private payers probably don't think about covering or reluctant to cover. And we provide that service not just for the injured person, but also for their families if we can. We cover transportation costs because access to health care, access to medical care is important. And those people who live in rural communities, they just don't have the ability to follow up with care. And we know that transportation is very important for that. We pay for personal care attendants at home to bridge the recovery, to get them to become more functional. We pay for extended post-acute rehabilitation costs, where again, it's the same idea, the bridging the care needs and the time it takes to get individuals with catastrophic injuries to develop more self-management skills and being able to better function on their own. We also pay for home modifications. We have to make adjustments in the homes to ensure that the safety and the functionality is assured. We also pay for DMEs or equipment that actually I think support the functional level as well as health maintenance that may be needed, including vocational rehab, education, training to help them find, develop skills to find employment. Interpreter services, things we don't think about, but I know as an acute care facility provider, we have access to interpreter services to make sure that people understand what's going on. But outside of the healthcare acute care facility, interpreter services are not paid for. But we do that to make sure that the family members and the injured people understand what they have to do to take care of themselves better. And then lastly, we know the importance of periodic rehabilitation therapies to ensure that the level of functional functioning and their health maintenance are maintained. Because if not focused on, it will decline over time, and we need to make sure that they're able to get back to their the level of maintenance that needs to be to support their functional ability and overall health going forward. So with that, what's needed? I think there were a lot of comments that were alluded to earlier, and I'm going to repeat that. And I do want to say that it's a multi-pronged approach to try to figure out a way to better support our population with catastrophic injuries to not just survive, but to thrive. And I think it starts with the model system. It's already being done. And I commend all of the researchers and physicians and scientists who are in the model systems making this happen. But we do need more evidence, more studies that will give us a better understanding of the trajectory of the functional outcomes for different groups of catastrophically injured population with different clinical severity. We also need to better understand the impact that maybe some of the interventions and sites of service and maybe even a certain framework, the care management framework that we're talking about, both integrative as well as collaborative, will have on the trajectory. What moves the needle? And then the other important element that I think that we all need to address is really to promote the knowledge equity. I think there definitely is a gap, and I will say this and with confirmatory feeling that there are a lot of providers, frontline physicians, and even specialists who do not typically deal with catastrophic injuries, and there is definitely a knowledge gap, and we got to make sure that they understand fully the long-term chronic health issues associated with these catastrophic injuries. And then lastly, from a policy perspective, I would love to see the efforts that are being made by all of you in trying to get the payers and our country to accept the catastrophic injuries as truly what they are, which is they are chronic healthcare conditions. And then lastly, to try to expand the coverage and payments for those non-traditional services that I just shared with you that we pay for and we're able to pay for to support the population with catastrophic injuries to do better. So with that, I want to end here and thank you for your time. And Jeff, we'll open up to, I guess, any questions that anyone may have.
Thank you, Dr. Chu, for that excellent tour of your perspective from Paradigm and thinking through these issues of chronic conditions after traumatic injury from your viewpoint, which I think has been just tremendously valuable to this conversation. I want to ask all the panelists now to, if they can, to turn on their video, and we're going to open up to Q&A And I believe we have some help from some people to help curate the questions that have been coming in for the group, the panelists.
Yes, so thank you everyone, and thank you to those of you who have submitted questions in the Q&A box and the chat box. Just to start, there has been several comments from several participants who have raised concerns about care providers' reluctance to order things like referrals. And so we were just wondering how recognizing these injuries as chronic conditions might address some of these concerns.
Dr. Chu, do you want to maybe pick that one up first? What's your take?
Oh, I apologize. So
No, wait, I just figured you might want to just start.
yeah, sure. I'll give you my perspective. Obviously, I think there's probably two issues. One is that to the point that was being made, the treating provider may not know enough to order maybe a specific test that may be related to catastrophic injuries in these complex cases because they may not know. It's a knowledge gap. But the other thing is that I think sometimes what confounds this whole process is that some of the treating physicians may not order the test because they're not certain whether it'll be reimbursed or covered by payers, especially when it comes to certain specific testing. So I think the reason for the reluctance might not be exactly knowledge gap, but it could also be because they're experienced with the payers and what's covered. If that helps.
Dr. Hammond, did you want to add to that?
Yeah, I was just going to say that over the years, the education of healthcare providers has been of our thinking at the time and wasn't really of the nature of telling us that people can improve and people can decline over time. And so just even healthcare education hasn't prepared us for making sure we do the referral or do proactive care.
I was just going to add that, you know, it's potential that this work to designate these traumatic injuries as chronic conditions would help in developing sort of care guidelines that will become more sort of standard and pathways that will be, you know, paved for the care of patients that meet these conditions. And it wouldn't just be, you know, one-off clinicians trying to figure out how to manage each individual person, but there would be more of a established care guidelines that would help not only the very experienced clinicians, but people who are experienced as well.
And there's another question in regards to case managers and the primary care team and the need for education. And so any thoughts on how we might, you know, address shortages for positions like case managers or education for other providers who are not specialized in TBI, SCI, or burn injury?
If it's okay, I'll just chime in. So obviously Paradigm, you know, we specialized in providing care management services to our population with catastrophic injuries for the long term, for the long haul. And I think the challenge is exactly what was mentioned, that I think there are a limited number of care managers and I think care coordinators who have experience in managing catastrophic conditions. And so the educational piece is very critical. The problem though is that the demand and supply. The demand I think is so great right now and the supply is so limited that you know, obviously there's a gap. And education is one element to try to counter that through, I guess, information sharing and maybe training. But I think there's a really a difference between someone with experience versus what I consider to be a book learning. And so, obviously experience comes with time. And so I think there is going to be always be some gap between the proficiency of the care managers in assisting the population that we're dealing with. So this is my 2 cents. But I think it's improving. It's just that we just have to do more and get them more experience.
Audrey, the Greater Boston Chapter of United Spinal right now is actually working on a grant to apply for funding for a community care manager. And it's to target individuals who've been discharged into nursing homes. And this is for spinal cord injury in particular. And it is somewhat a diamond in the rough that we have found someone who is a licensed occupational therapist and has a child with a significant disability. So she's been through the system, she knows the system. So hopefully that will enable us to, again, fill some of the gaps in service post-discharge from, acute and rehab, where people just don't have the resources to go back into the community.
Right.
I think we know that the coordinated care model works. There's pretty good evidence across disease categories that complex medical conditions can be pretty well managed in terms of reducing complications, rehospitalizations, et cetera. The problem is, and Dave just alluded to this, is that there's no reimbursement for a care manager specifically. So how do you access that care model? It's typically going to be inside of an institution, either that an insurer has, like Paradigm, or a large hospital corporation has already funded. But if you're not part of either of those two large institutions, it's very difficult to access that service. So it's a shortage problem, but it's one that's shorted by the fact that that there isn't a funding mechanism for that model of care, despite the evidence that it works really well.
And so we have another question about peer support and community-based resources. So is there any evidence that peer support and community-based resources improve outcomes, as these seem to be central themes in the stories that were shared today and what we hear in our work working with these populations?
I think it's a great question. Go ahead, Joe. Sorry.
No, go ahead, Dave.
No, I think we need, in terms of our smaller nonprofit organizations, we have a great collaborative relationship with Spalding and other entities, but I think we need to work to improve assistance in gathering data, because as one can imagine, most of our smaller nonprofits they're all volunteer based, don't have the knowledge to collect data and do specific research that could be fruitful for pushing some of these issues along that we're talking about now. Do we know peer mentoring and support groups help? Yes. Do we have the data to back that up? Not necessarily.
I know that, go ahead, Dr. Savant.
One thing to consider is some work that's being done, and we're beginning to look at, David, and how people relate to each other, related those peer support networks, and those connectivity between persons in those networks can be used to manipulate and manage a lot of comorbid conditions and direct people to preventative kinds of activities. And that's been done in MS already, and may serve as a great predicate for spinal cord injury and other conditions.
Audrey, I don't know if it's possible, but Greg Ayotte is on the line from the Brain Injury Association of America, and I don't know if he has audio capability, but I'm guessing Greg would be willing to say a few words about this topic if he's able to do that. Would he be able to speak?
Yes, he just would need to unmute himself.
Greg, would you be willing to say a few words on this? Can you, I'm not sure if you're talking. I heard very faintly your voice for a second. Okay, maybe Greg can't get his audio going. Okay.
I can chime
Other
in while we're
questions, Audrey?
waiting. I was going to add to that, you know, I think Amy Acton, who's the head of the Phoenix Society, put that question in, which knows somewhat about this, but and has worked with us on this work, which is, you know, we have looked at some preliminary data looking at peer support and its association with community participation outcomes in the burn survivor population. And using data from the Libre study, we found that, you know, there were some really nice positive associations with success, you know, in social participation domains or outcomes, how people are doing, living their lives and getting out and doing things. For those, we're doing better for the people who were engaged in peer support compared to those who had not been. So that was some data. It wasn't the most definitive, but it certainly is pointing in the direction that we see here and people are attesting to, you know, anecdotally, and which we all have seen, you know, in our own lives.
And another question is, how can the model systems programs promote research and changes in policy around this area?
Let's go to Dr. Hammond.
I was going to listen for the answers. I was ready to take notes. Well, certainly all of us across the model systems are working really hard to talk about this and think about it and brainstorm on solutions. And then each of us, and we started a special interest group across all the model systems to even share knowledge across the 3 model systems. And each individual site, as you're preparing every 5 years, preparing the application, can do research on these areas as it fits their strengths at their site. So I have seen over the past 2 decades that several of the model systems applications have been doing research in this area. So we're starting to move the field through the model systems, and then we work together through our special interest group to create awareness, knowledge, teaching materials, and trying to get the word out. And in fact, for the brain injury model system, made a policy sheet to try to help educate policymakers.
Hey, Flora, can I ask a question?
Sure.
So I actually, it's a question and a comment, maybe a challenge. I think from a policy perspective, I think unfortunately some of the policy is driven by the undercurrent of the impact on finances and the cost. And so I know a model system has done a fantastic job of really diving deep into research about clinical issues and factors that impact outcomes functionally. But I know that you know, sometimes trying to correlate the outcomes to impact on cost has always been more speculative. It's more kind of an assumption. And is there maybe a consideration to change that by collecting different data sources to add to the clinical data that the model systems are collecting, to have some ability to make some statements? Does that make sense?
Yeah, you know, I think in our cross-model systems special interest group, you've brought up some things that we can talk about, such as cost data, and one of our other challenges is a control group. Those are 2 things that frequently come up, but yeah, we don't we're not able right now to capture a lot of the cost data in an accurate way. And we've discussed that over years, but maybe we can figure out some solutions.
Right. And just as a consideration, one of the things that I think Paradigm has done over the years that truly, I think, bolsters the idea, the concept that doing the job well up front and getting people to the best functional level actually saves money the long term. And so we actually use actuarial data, and we use our internal financial cost data sources to project that. But I think it's not easy, because sometimes getting cost information is not always the easiest thing to do. But I think that probably will move the needle maybe more from a policy perspective than I think than not.
Michael, you bring out an important point. Many of the payer sources are not committed for the long term for the people they insure. So they may not have the long-term consequences of functional outcome, whereas in your model with Paradigm, that is the commitment.
Right. Yeah.
We're coming to the end of our hour and a half, and I want to be respectful of everyone's time. First, I just want to thank all the panelists who were here today and shared their stories and their perspectives, and all the attendees who came. This will be available online, and if you have further comments and questions, our hope is that this will be a trigger that will help us, push these efforts forward and help us springboard to really continue to work on addressing these issues across all these populations that we talked about today. So
also, just want to can
Yeah.
I just, before we hang up, let everyone know, it's in the chat, but there's a wealth of information available at the Model Systems Knowledge Translation Center, msktc.org. Take a look at that website, all kinds of different media that information is available in. The MSKTC is also involved in advocacy efforts as well. So take a look if you get a chance. And I want to thank everybody as well. It was a pleasure.